changing my stuff.
Oh, thank
I
you.
don't want to carry it around.
It's still early, aren't we?
It's much late. It's 11:30. Thank you. Everybody else is gone. Cardless. We're asking everyone to please sit at a table that has a number. There are 5 tables. Steve.
Yes.
Hi, Christine Sutter.
Hey, Christine, good to meet you. So glad we're on a panel together. It's one of these things where you do a panel and then hopefully you meet each other the next week. That's the way it works, right?
I'm in the middle of moving.
Oh, no.
Yeah.
From where to where?
Ellen has been so kind. She's like brought me over documents and stuff from Rockville to Bethesda,
Oh.
but we're in boxes.
Oh my gosh. One of the worst experiences of my life has been every time I've had to move.
This is
Good morning, everybody.
within the same country, so yeah, we can do that.
They don't make these podiums for short people. Or maybe there's a requirement. Well, good morning again. Glad to see everybody. It's kind of interesting to watch what's happened, that nobody's at table 5, which is okay. Just kind of curious about that. So thanks for coming. My name is Ellen Eisman, and I'm one of the co-chairs for the SID-Washington work group on international health and nutrition. And my co-chair, Elvira Barracochia, is right here. I'd also like to recognize a couple of other people who helped make this happen. We are co-sponsoring this session with the gender co-chairs and the education co-chairs. So one education co-chair I know who's here is Stephanie Thangavalu. Thanks for coming. Is Anna Flores here? Okay. And the gender work group as well. The 2 co-chairs are Jennifer Collins-Foley and Christina Manfrey. So everybody's kind of splitting up and going to different places because there's a lot of co-hosting these different events. We're really excited to have this panel today. It's been a long time coming, and we were talking about the issue of health and poverty and education and gender before decisions were made actually about what would happen. So we've been working on this for months, and then we got really excited that we were able to find this amazing group of panelists. So I think you're in for a real treat. I know 3 of them. Well, I know all 4 of them now, but had the chance to interface with them. They've been working really hard. We've had meetings. They've been sending stuff back and forth. So that's why you have on your table some materials. There is a book called Frontiers, and there's an article in there on poverty. You're welcome to take one if you'd like. There's a resource list of items that we also felt if you wanted to do a little bit more work and follow up. And then there's a handout that's in color, and actually that has some graphics on it that will be referred to by the first speaker. So that one for sure you should take. So to get going, because we have a lot to cover, we are going to have the panelists speak. We're going to have some group work, some report outs, and I just want to say we're going to do this is being recorded. The only mics that you can talk into that will then be recorded are the ones up here, and then the 2 that are on the floor. We've asked you to sit in these 5 tables because of some group work, but also this is being videotaped. So if you think the back of your hair is not looking good right now, you might want to fix it. And then it'll be up on the SID-Washington website, so you can go back and look at it later. And we will do our best to get these handouts uploaded as well, and any notes that take place from this session, so that you don't have to be sitting here taking lots of copious notes. So I think that's all the information so far about the logistics of this. So let me get started. The session is called Mitigating the Effects of Poverty on Health Outcomes. And once we started working on this, we realized how everything is all mixed together. And this morning you heard the word integration come up numerous times, as well as partnerships. So can I ask you guys to join one of the tables, please, with a number? Okay.
You can still join.
Or not. Anyway, let me introduce Ken Yamashita, who's our moderator for today, and he'll be introducing the rest of the speakers. I've known Ken since about, well, the early 90s, let's just say, when neither of us had any gray hair. We met in Ecuador when he was the director of the health office there for USAID. Ken has the most amazing background, so I'm going to talk fast to get in as much as I can, and if I get any of it wrong, I'm sure he'll make a face and we'll correct it later. Ken has his PhD in public health with a focus on population dynamics. He worked for CDC, he worked for Futures Group, United Nations, and then he got involved with USAID. So going from in the back to the front, or past to the future, as I mentioned, he was the director of USAID's health office in Ecuador, which is where we met. He went on to be the policy division chief at the Global Center for Health, Population, and Nutrition for USAID here in Washington. He became the director of the Office of Health in South Africa. He's been a deputy mission director for USAID Peru, where we reconnected again. He was mission director at USAID in Kosovo. He was the director of the Office of HIV/AIDS for USAID here in Washington. Acting administrator for Europe and Eurasia for USAID. I think you were also the mission director in Europe and Eurasia, Kosovo, there you go, thank you, I said that. Acting administrator for Europe and Eurasia for USAID in 2009, mission director in Colombia, mission director in Afghanistan. I could go on and on. This guy has amazing experience. So he's certainly an expert in the area of health and all of the issues that we're going to be discussing today. So if you'll join me in welcoming Ken as our moderator.
Thanks, Helen, and good morning, everyone. Just to remind those of you who are at tables without a number, if there are still seats at tables with a number, please join. The reason why we have the numbers is it will be an interactive session. We learned from last year that the interaction amongst and between the participants was something that everyone enjoyed. So after our presentations this morning, we'll have an opportunity to have discussions at each of the tables. And then after the discussion is over, we'll have some quick readouts from the different tables and a question and answer period, so that hopefully it will be very much an interactive discussion this morning. With respect to the topic that we have and the title, One Factor, Multiple Disruptions, as I thought about it after Ellen asked me to take part in this session, I started thinking, well, is it one factor, multiple disruptions? Is it one disruption, multiple factors? Is it multiple factors, multiple disruptions? What is it? And then, of course, I see the overall theme of this conference, which is evolving development, navigating disruptive change. And really, I think that the answer is all of the above. We are at a point where there are an exceptional number of complicated issues affecting our development processes, all issues interrelated at one point or another. And there is no question that it is the same in health. Poverty is a lifestyle. It is not a lifestyle of choice, but it is a lifestyle nonetheless. Before this session, when I was having a conversation with our panelists, we talked about poverty, the poverty trap, and how difficult it is to get out of it. So if it's this complicated, and if it's this multi-sector, then how do we as development practitioners, how do we address it? What is it that we can do, practically speaking, that will begin to unravel some of these complications? And we can start to think about what it is that we can do, whether it be as individuals, as institutions, as a development community, to try to get out of it. Or do we just throw up our hands and say, it's impossible, we can't do it? Obviously, as development practitioners, we do not throw up our hands. We try to do what, well, once someone asked me, how do you eat an elephant? One bite at a time. And so what we will try to do, and through our presentations this morning, start to unravel some of these complexities. We are exceptionally fortunate to have three wonderful, experienced development professionals who have thought long and hard about the multiple facets of poverty, about the interlinking pieces, about the multi-sectoral causes of poverty. And we have professionals and experts who have also thought a lot about health, and specifically about health services, health outcomes, access to health, health-seeking behavior, and overall context. So we will have that this morning. Each presenter will have about 7-8 minutes. It's not a lot of time to start talking about this, but hopefully we'll have an opportunity to at least scratch the surface and get the conversation going. We have first Steve O'Connell to my immediate right. Steve is chief economist at AID. He's on leave from Swarthmore College, and he has been at USAID. He has been championing the framework on poverty. It is a framework that has been worked on at USAID for some time, and we're very, very fortunate to have Steve here with us this morning. A lot of his work is in sub-Saharan Africa. He holds a PhD in economics from MIT. Steve's talk this morning will be to really start a conversation about the overall USAID approach to poverty, the framework that I believe is captured in the document you have at each of your tables. Then next to Steve is Marilyn Rice, Marty Rice. Marty is CEO of Marty Rice Consulting International. And she has been working in health and health-related development issues for a very long time, over 40 years. She has worked with PAHO, she has worked with the World Bank, numerous other organizations. She is a board member of various international organizations and institutions. Marty's going to share with us some of her thoughts on what is the context within which poverty and health take place. What is going on at the community level? What do we mean when we talk about the poverty trap? What else needs to happen, especially at the community level, so that individuals can get out of the poverty that they are in? It is not just about one single action, but it's multifaceted. How do we start thinking about that? We'll hear some thoughts from that from Marty. And lastly, Christine So. Christine is the President and Executive Director of Global Health Council. I'm sure all of you have heard about the Global Health Council, but just a little plug, it's a fantastic organization. And if you haven't joined it, by all means do. It's, along with SID, these are great resources for all of us who are in development and in health development. Marty also has a large experience, over 20 years in global health and development. She has led numerous initiatives to strengthen health systems. She has worked for nonprofits. She has worked for UNICEF and USAID. She has a PhD in epidemiology from Tulane University and a master's degree from the University of Michigan. Christina is going to share with us the changing nature of the health context globally, in particular the epidemiological and the demographic transition, what it means as we see, I think, our collective success in starting to address the issues of infectious disease, and more what we are starting to see in countries around the world, which are issues of chronic disease. And what does that mean, especially at the individual family level, when they are faced with such crises? How quickly they can fall into poverty and how difficult it is for them to get out of poverty. So please join me in welcoming the three panelists. And Steve, it's all yours.
Thank you very much, Ken, and thanks to the Society for International Development and to Ellen for inviting me. There are two things on your tables that I'll refer to very, very briefly. So one is a one-pager, a very complicated-looking diagram. I will talk about that very briefly. The other, the book, is there for you to enjoy. It was produced some months ago as a part of a larger process at USAID that is trying to work out our new mission. of ending extreme poverty. So that one is not directly germane, that book. I'll talk a little bit about this diagram. So the title of this session is Mitigating the Effects of Poverty on Health Outcomes. That's a unidirectional statement. USAID has a new mission. I quote, this is coming from President Obama's State of the Union Address 2013 and encapsulated in the following language. We partner to end extreme poverty and to build resilient democratic societies while advancing our security and prosperity. So that first piece, we partner to end extreme poverty, is a very forthright statement of our joining the global process, the post-2015 agenda of ending extreme poverty in all its forms. By 2030, in the post-2015 agenda, I think for us this is an open-ended commitment that we're going to work on until it's done. But I want to emphasize a moment of opportunity that drove us to adopt this very ambitious goal. So at the same time as the complications and the mutual causality are difficult, the accomplishments globally over the last 20 years give us a sense that a great deal has been accomplished and we can finish the task both on the income side and in some key health arenas. So I'm not going to try to exposit this diagram. I'm going to use it to distinguish two levels of analysis on this nexus between health and poverty. One is the household level, which is the one that matters ultimately, and that's at the top of your diagram. And USAID has adopted explicitly a multidimensional definition of poverty, where income poverty or consumption capabilities are part of what we mean by extreme deprivation. But so is extreme deprivation in health. So is extreme deprivation in terms of education and learning. So is autonomy and participation in society. So it's multidimensional from the start. I'm going to back up in my comments from that complication and look at health on the one hand and income poverty on the other, and the two-way relationship between those. Most of this diagram, the lower half, is about the economy-wide process that we think drives reductions in income poverty over the long haul and generates the basis for reductions in other dimensions of poverty, including health. The two-way nexus, health affects income and income affects health. The first half I could spend a lot of time on. It's the one that's best documented. It has some key dimensions you know of already. Health directly affects the productivity of the worker and the income generating potential. That is highly relevant even for the extreme poor. The survey data tell us that movements out of poverty at the extreme poor level, I'm talking the $1.25 level, over half of those movements are driven by labor earnings. So the labor of the poor is their primary asset, and health compromises the productivity of that asset. That's a direct impact, and it's big. Secondly, indirectly and intertemporally, poor health compromises the efficacy, the incentives, and the efficacy of investments in education. The household has less incentive to invest in the education of children whose longevity is uncertain, and the children's uptake, ability to attend school, and their cognitive capabilities are dependent on their health status, and very much for us in the first 1,000 days in utero and as an infant, with long-run effects. Nutritional inputs, health inputs at that stage have long-run effects on the income earning capability of the child. So health is critical for us in the intergenerational transmission of poverty, maybe moving us towards a concept of a trap that might work out over time. Let me now look at the harder part, and I'm going to give you some ideas about links now from income to health. It's harder because those links are slippery and they take time, and sometimes they don't appear to be very strong, but I'll distinguish aggregate links from household level links. So let's think economy-wide first. the links from the aggregate economy. Most poor households live in poor economies. Okay, so the global geography of poverty has moved very decidedly to sub-Saharan Africa, where the median household is often living under $1.25. So the entire economy is a very low-income economy. So the channels from the economy-wide poverty into health go through public revenues and the capability of the public sector to support public health delivery, and then more subtly through the institutional capability of the public sector. Not just spending, but the quality of it and its ability to withstand shocks. The Ebola crisis is an example of that second channel. There have been tremendous advances in particular categories of health, aided by external partners and by the Liberian ministries of health. But an external shock came and knocked over the local health capacity completely. That was a pointer to low, broad-based capacity within that sector. Finally, household level, I'll just mention links, and I suspect they'll be fleshed out further in the conversation. One, the autonomy of women in the household as it affects their fertility behavior. Highly, highly correlated with the income poverty of women and their labor market opportunities that help to back up their power even within the household. Secondly, household behavior towards risk. Low income means high risk of catastrophic decline. And risk behavior, therefore, drives a lot of behaviors that are related to health, fertility being one of the most dramatic ones. High fertility being a choice, dealing with the risk of high mortality of children and the risk of destitution in old age, and therefore wanting to have children to provide for you. The fertility then channels through to large families, especially when infant mortality rates start to fall as they have very decidedly. The fertility rates lag. Large families, poor families, low investment in children, and there you go. I'll just stop by emphasizing that the relationship from income to health is slippery. So you cannot have a health strategy that works only through income. Income is critical to sustaining advances, but direct interventions in health are highly efficacious and can help break into this two-way nexus effectively, even when income is not moving fast. Thank you.
Thanks very much. Just about past the time. Thanks, perfect timing, thank you. Let's go on to Marty.
Okay, thanks so much. I want to start off by thanking Ellen for organizing this, and Elvira and the Health and Nutrition Working Group, along with the Education Development Working Group and the Gender and Inclusive Development Working Group. So we've got a lot of sponsors for this wonderful session. I really want to talk about, give an overview of how I'm approaching the subject, and then talk about some very specific strategies on the ground, things that have worked in some of the countries. And the first thing I want to say is that I'm not going to talk about medical care or addressing treatment for diseases. I think that's an important part of health. I think Christine is going to talk about some access to care. But I want to talk about health. And how do we create conditions for people to be healthy no matter where they live, no matter what their income is? And in order to do that, we need to link with other sectors and with people working both in public and private environments. And to do that, we have to look at how we frame what we're talking about. And as long as we're framing what we're talking about as health, our partners are going to interpret it as disease, as illness, as treatment, as medical care. So what we've learned to do is to talk about creating a better quality of life and creating well-being in the population. And that is something that most, if not all of our partners can relate to. So that's number one. Number two, I think we need to look at the causes of the poverty and the other conditions that create conditions in which people can or can't be healthy. What WHO refers to as the social determinants of health. So in terms of social determinants, we get things, for example, like transportation. If people do not have access to transportation, and transportation that's good transportation and safe transportation, and economically accessible transportation, they're going to have trouble getting to jobs. getting to education, getting to other kinds of services. So there are what we call the other determinants of health that aren't just in terms of access to care, transportation, education, good housing, where people not only have safe housing, but housing that's built somewhere where it's not going to slide off the side of a mountain or slide into a river. Those are all conditions that we call the social determinants of health. There are many more, but just to paint the picture of what is it that creates a condition or inhibits a condition for people to be healthy. And I want to give you some examples of policies and programs that have been done effectively to try to change some of these things. And what I want to say first and foremost is none of these have created parallel structures or vertical structures or parallel systems. They have all been built upon what's already been there. So not necessarily an injection of new resources or new systems, but reorganizing, rethinking what's already in place. So one of the areas I want to talk about is support to the local economy and local priorities. And one of the things that was done in Brazil as part of their Zero Hunger project is they have a national school feeding program. Many countries have this. But what happens is the federal government gives money to the state, which then goes down to the local level. And what the federal government said in legislation was 70% of this money has to be spent at the local level, and it has to be spent on healthy foods. The impact of that, just that one policy, was tremendous. Because first of all, it helped to bolster the local economy. Instead of giving money to the big industrial food producers, the McDonald's and the Coca-Cola, it went to the local level, so economically, the local level improved. It provided more, better, healthier, fresher food to the schools and to the school children so that they had an opportunity to be healthier. So it was a win-win situation all the way around, both for the country as a whole as well as for the local level. Another strategy that's been very effective is what's called participatory budgeting. And I'm sure a lot of you in the room have heard about that. And what it means is the local authorities, the local mayor, the municipality, takes a percentage of their budget, whether it's 1% or 5% or whatever they deem that they're going to allocate to this, and the community itself decides what the priority is going to be and how that money is going to be spent. So you end up getting things that aren't necessarily sectoral. You may get the development of a community center or a soccer field like we were talking about in Peru. And what happens when the community itself comes together to decide on its priorities is that it begins to develop community cohesion. It begins to feel empowered to somehow change its environment. And it begins to build places, spaces where the community can come together and work together. And that begins to transform the community. When you know your neighbor, you're working together with your neighbor for a common good, it totally changes the way you approach life and the way you begin to feel invested and improve your community. The other thing that's happening in terms of sharing local priorities and solutions is the internet and what's happened with social media. And through social media, countries have been able to come up with low-cost systems to train personnel, be it in health or other sectors, to share positive experiences, but also for people to share their dilemmas. And they may be in different places in a given country or across countries, and they can say, I've got this issue that I'm dealing with. Who else has had to confront this issue, and what have you done that's been successful? So that's just some of the things. I could go on forever, but those are just some of the things in terms of addressing local economy and local priorities. A second area I want to talk about is how we begin to maximize local resources and build a multiplier effect. And the first thing I want to talk about is making the invisible visible. Because as long as we don't document what's going on in terms of capacities and resources as well as problems and issues, we are not going to be able to address them. And normally, all of these things are done either sectorally or at a global level, citywide, countrywide, district-wide. We're beginning to say that's not good enough because we can't identify where the true issues are, where the true gaps are, and where the true resources are. So now countries are beginning to use instruments to assess the whole situation down to the neighborhood level. And when you get down to the neighborhood level, you not only identify the issues, you can identify the assets, you identify gender discrepancies, ethnic discrepancies, cultural discrepancies. So you're beginning to identify ways to have entree into that community. You look at the physical infrastructure, and you also look at the economics and governance. So through this disaggregated data at the local level, very comprehensive, you're able to then feed into a more comprehensive solution. Through that, you can also identify who are the real local leaders, who are the real decision makers, even at the household level. Is it the grandmother? Is it the local healer? Those are people we need to work with to make sure that culturally, whatever changes are going to take place will be sustainable. But also to work with the power brokers and the mayors. And I want to share with you an experience that we had in Central America and Panama, where we were able to reduce by 63% the incidence of malaria. And we did it by giving the mayors the authority and reinforcing their authority. They had the leadership, it wasn't the health sector. So the mayors reallocated the resources to building bridges, to sustaining the walls of the rivers so they didn't overflow. The communities organized to have community cleaning brigades. And at the household level, people took more responsibility for household hygiene and for cleaning up stagnant waters in their community. The third and last area that I wanted to talk about was sustainability across political transitions. Every country has political transitions, and as long as the programs are in the hands of the major decision makers, there's no guarantee when all of that changes that it's going to be sustainable. So to the extent that these initiatives can be developed with an alliance of all the possible stakeholders at the local and national level, a political transition will not have the same impact. Things will be sustainable because the communities will say, but we've been doing this for a long time, and this is successful, and this is of interest in our community. So we really need to keep this going. And it's in your interest to keep it going. We've developed networks across countries to share those experiences, and the Healthy Municipalities, Cities, and Communities Network is very strong. It started in Europe, it came to the Americas, it's now beginning to take off around the world, where mayors and local authorities are sharing their experiences and talking about what they're doing. And in line with that, there are some mayors who have put up on the internet what's happening in terms of their programs and their resources. And by having this visible to the public, it really helps to curb corruption, because the public can see where a resource is going, which programs are being effective, which programs are not being effective, and they're beginning to hold the government more accountable. And then finally, in terms of sustainability, if you're having an election and you can get to all of the candidates in that election, for them to put quality of life, well-being, and health on their agenda, then whoever is elected has vocally, publicly talked about how they're committed to those issues and sustaining those issues and putting resources into those issues. So you're not taking sides, you're not picking a party or a politician, but if all of the people running can understand the value of this and commit themselves to it, then you can be assured that you'll have some resources to follow up on those programs. Thank you.
Thanks very much. Thanks very much, Marty. Let's go on to Christine.
Great, thank you, Steve. Or thank you, Ken. And I want to just add my voice to all the thanks that have already gone on for the organizers of today's event. I think we were all very pleased to be asked to be part of this panel. And kudos also to that cross-sectoral thinking around how this was organized. So I think I'm going to take us up a little, up a level, or maybe up to 35,000 feet from what Marty was saying, but I think she and Steve's comments helped frame what I want to talk about just ideally. So when we talk about and think about health and well-being and quality of life, as you were mentioning, we're coming out of a paradigm where we've really been thinking about development as rich and poor countries, rich and poor societies. And when we think of health in that context, we think of good health and bad health, and that people in rich countries tend to have good health and people in poor countries tend to have bad health. And with a big emphasis in poor countries on mortality, child mortality, maternal mortality. And that is fairly accurate to where we have been. But now we really are seeing a shift in global demographics, the aging of the population in the global north. We're seeing shifts from rural to urban living all across the world. So really radical changes in how people live and where they live. And we're also seeing that what we've been engaged in so far, really concentrating on mortality, and in particular around under 5 mortality in the global south, is having an effect. We've halved child mortality over the last 20 years. So we've made great strides. But along with this demographic transition, we're also seeing an epidemiological transition. So we're going from a focus on acute disease, on infectious disease, on child mortality, maternal mortality, and we're actually moving into a landscape that looks a lot more towards chronic disease and what that means. And again, kind of, I think in our paradigm that we're coming out of, we tend to think of chronic disease as, you know, somebody sitting on their couch and eating potato chips and watching TV and maybe smoking a cigarette, and so that all culminates in poor health, chronic poor health, at a certain age, so in your 50s or 60s, and again in high-income countries. But in fact, what we're seeing now is that as people move into urban areas, they have much different access to food. They lose knowledge and traditions around raising their own food and how they eat and how they cook. We're seeing shifts from undernutrition to poor nutrition, where calorically speaking, we may still be getting enough calories or probably too many calories, but what the quality of those calories is shifting radically. People, you mentioned transportation, you know, people have now different modes of transportation. They're not walking as much, they're not as engaged in physical labor, and so again, their caloric output is very different. And we're also seeing the effects of bad pollution, or of bad air pollution, environmental causes, all having an effect, again, around an uptick in chronic disease in these populations. Now, again, we have, when we were dealing in the paradigm around child survival and maternal health, at the same time, we were looking at a move towards user fees. So in the 80s, 90s, we had health systems that were built around at least having a token payment for user fees, and we were seeing that from high-income countries down to the poorest communities. We now are realizing and acknowledging that, in fact, even the smallest user fee can push somebody either away from services, or if they're having some sort of a catastrophic health event, that it can push them into poverty. And once you're in poverty because of a catastrophic health event, it can be much harder also to get out of it, because you are dealing with the ramifications of whatever health issue you have, and you're having to output in terms of paying for care, and it's much harder to come back out of poverty. So along with this demographic transition that we're seeing now, we're also seeing a movement towards universal health coverage. And one of the important things about universal health coverage in and of itself, and also as we move into the Sustainable Development Goals, is that now we're really talking about universal goals. We're talking about not just low and middle income countries. We're talking about everybody engaging in universal health coverage, engaging and committing to the Sustainable Development Goals. And so this is getting us away from the idea of payment at point of service and much more towards payment either through subsidies, insurance, or other schemes that may be underwritten by the government that require payment outside of the actual point of service, and in doing so will theoretically be put people in less vulnerable positions to then start that slippery slope into poverty. We need to think about, as we're moving towards universal health coverage, focusing on the most vulnerable and the people who may not be covered by formal schemes. So, you know, if we're thinking about employer-based insurance, lots of people don't operate in the formal economy. You need to come up with schemes that actually allow them to have access to that kind of coverage as well. So we've got these two movements. One is demographic and epidemiological. The next is economic and payment. And where are we going with all of this? Well, you know, when we think back to this question of chronic disease and poverty, again, we see chronic disease hitting people right when they're wage earners in bulk, but we also see it hitting younger kids. We've got kids with children's cancer, with diabetes, and in lower and middle income countries, we've got much fewer resources to actually treat this. And it's been harder to convince lawmakers both in LMICs but also in the United States, to actually shift resources into looking at chronic disease. We have to look at this as something that starts in childhood. Again, you've got kids establishing the way that they eat, establishing the way that they think about food, establishing how they think about exercise, and all of this builds up so that when you're an adult, it is a lifetime accumulation where it can actually radically affect how your health is manifesting itself within this context of do you have access to care? Do you have financial coverage for the kind of care that you need? How are your chronic health conditions affecting your ability to participate as a wage earner within the economy? And how are the costs of your care affecting your family and your community, both in terms of individual payment, but also what the community may need to support you. So, we work with the U.S. Congress and we work with agencies, and if we say to a staffer on Capitol Hill, we should be thinking about how to pay for chronic disease, it goes back to this idea of, well, why are we going to put U.S. taxpayer dollars into dealing with somebody's chronic disease that they got because they're, excuse the term, fat and lazy and sitting on their couch? And you have to say, okay, but you have to look at it in the paradigm, and you have to look at how this is all shifting globally, so that you can actually say, we need to do this now, we need to do this as prevention, we need to get people eating right, exercising, having access to healthy transportation, having access to healthy cities, having access in rural areas to the kind of care that they need, which is different from the kind of care that we've been providing thus far. I'm just going to end with one last thought, which is Steve mentioned President Obama's comments about ending extreme poverty. I think it's worthwhile mentioning that while the highest levels of the administration are talking about this, just recently the U.S. government released the Quadrennial Diplomacy and Development Review, and Secretary Kerry referred to it as the blueprint for the next generation of American diplomacy in development. In that report, which is 40-some or 60-some pages long, it's a hefty report, one paragraph on health. And I think that's noteworthy, because if we're talking about the relationship between ending extreme poverty, if we're talking about economic growth both in the U.S. and elsewhere, and we're looking at the U.S. government to be the leader in those areas, and I think we see our agencies being very much engaged in that, we also need to be having that echoed in those formal documents that are stating USG positions. And so I think that gives us all some homework to do to keep pushing in that direction. So I'll stop there. Thank you.
Thanks very much, Christina. Can I just thank all the panelists for the excellent presentations, recognizing we are very much scratching the surface of this most complex issue, and thank you for staying on time. Clearly a lot to discuss, and the presentation by panels is only part one. Part two is now your job. What we'd like to do is, for the next 20 minutes or so, have each of you at your tables have a conversation about some of the big issues that were raised in these presentations. You should have at your tables a list of questions. Okay, we're going to give them out right now. As to giving them out, let me just give some additional requests. I would like to have each table assign a scribe and more or less a timekeeper. I'll also be timekeeper from up here, but most importantly a scribe. And the reason is we would like to get your notes and your thoughts and your questions up on the web, the SID website at the end of the session. There is so much to discuss on this issue. We recognize we're not going to get to all the questions and the issues that you may raise in your discussions, and I'm sure many of you have questions to ask. So what we'd like to do is have you have a discussion. Our panelists will join you in the different tables to add to the discussions you're having. At the end of about 20 minutes or so, we'll have a quick summary and some final comments from the participants. I don't know if there are any questions as to the procedure, any clarifications I might be able to give? Okay, for the 5 tables that have numbers on them, I would ask that you try a stab at the question that's associated with the table. So table 1 with question, each question should have a table attached to it, table number attached to it. So I would ask that you start having conversation about that question. And for those of you in the extra tables, pick the question you'd like.
I've actually given everybody a table number.
Oh, okay, she's being tricky. Oh, well. 5 minutes, please. I'm going to ask the panelists to make their ways back to the table, please. Okay, thank you everyone for what was certainly a very rich, certainly short conversation about some of these issues. I won't begin to say that we've resolved all the world's problems about poverty and healthcare, but I think that just listening to the conversation, there's no question that we have an enormously experienced and rich, I think a rich group here that has had a number of experiences, a number of ideas, and hopefully, at the very least, the sharing of experiences was very useful to everybody here. What I'd like to do now is ask our panelists for some 3-4 minutes of final thoughts. And I think we may have a little time at the end if there are any lingering thoughts or questions from the audience. And then we'll have some final instructions from Ellen. So begin with Steve.
Okay, thanks very much. And so I'm speaking here for Taylor, Alana, Andrea, Zan, and Elvira. And we had a rich discussion. Our question was, as to table 2, as development practitioners, do we have to do everything, do it all? If we focus on health, what is our contribution to breaking the poverty cycle? So I'm doing as a preface, sort of, we had a discussion of the idea that had come up in the discussion of rebranding health as well-being. I think Christine's idea, and there was enthusiasm for that at the table, and then immediately also a discussion of how health has had the tremendous advantage in the budgetary and political space of pursuing very measurable targets, and well-being could make that a tougher call, a tougher thing to do. So that I thought that was an interesting point. That led to a discussion about whether we need multi-sectoral efforts, essentially, and there was a strong sense in the table that the verticalization of programming tends on balance to be a limitation on effectiveness. There's a trade-off between going deep and getting it done and in going more horizontally and strengthening the system better, but our view was that at some level, local health systems have to be able to support the integrated delivery that's the characteristic of local health delivery. It's got to cover the full range of health issues at the point of delivery, and somehow building our systems that can strengthen that horizontal capability, and at the same time that can build the whole supply chain that's feeding it, including training, is critical. We had some examples of integration that are already sort of built in. Agricultural programs integrate nutrition very strongly was the impression at the table. Universal health care push, which certainly USAID is strong in Asia, for example, and some other areas, is a good example of a very horizontal kind of push. that covers a lot of ground. On the question of whether what's our contribution if we focus on health to breaking the poverty cycle, I think that question got reinterpreted as, do we ever speak within the health sector of the poverty impacts of our work? They're there, but they very rarely, was the thought at the table, they very rarely motivate the lobby arguments, the budgetary arguments that the health sector takes up to Congress and comes away successfully with. And I think that, so the thought was, those links are there. They're complicated, they operate over the long term sometimes, but maybe they could be, should be fleshed out better. Final point was the notion that health investments are central to our concept of equality of opportunity, which at least in the United States has broad kind of bipartisan appeal. The notion that it is the labor of the poor, after all, that is their primary asset, and the system can be configured to reward labor effort, but if the endowment of labor, the capacity to invest in the quality of labor is compromised by inadequate investment at the very early stage of life and by inadequate investment as the household faces health shocks, then you really don't, you haven't achieved a situation in which you have equality of opportunity. So that link from health through the work of the poor pulling themselves out, and the prospect to do that in the economic systems they're living in was a theme we discussed. So I won't go further than that. I'll respond just very quickly, take one more 30 seconds if you don't mind. Christine's good point about the QDDR, the Quadrennial Defense and Diplomacy Review, 2015. You can find it online. This is the counterpart of a commitment that the Clinton administration, that the Obama administration made under Hillary Clinton to elevate development to the level of defense and diplomacy. So it's very important for the development community. And admittedly, the health paragraph is a paragraph. I'll just say that the extreme poverty mission of AID is central in the document. And so the argument I tried to make earlier that health is integral to that vision, at least ports health in through that entry point. I think it's critically important for us. As you know, health is the biggest thing that USAID does by a big margin.
Thanks, Steve. Marty?
Okay, I have the privilege of reporting out on Table 3, which was, if poverty is so multifaceted, do interventions to improve health outcomes serve as a catalyst for breaking the lifestyle circle of poverty? And to begin with, our table very much felt like we needed to go beyond the word health. We needed to be talking about well-being and quality of life, and that by its own nature was going to be intersectoral and bring together the different sectors. We talked about how to engage families at the household level, and we learned of an experience where people were separated out at the household level and at the community level by different ages, and then they got information about food and nutrition with other people from their age group, and that by itself led to permanent lifestyle changes and different ways of thinking about food and nutrition. But we also talked about the whole idea of food deserts, and we came up with some solutions that are being tried, such as community gardens and school gardens, and the whole opportunity for communities to begin to counter the social marketing of not such healthy foods. We talked about teaching communities about finance and resource management and the outcomes of microfinancing when it's done with women and how women tend to invest back in the community. Now that helps to address the whole poverty issue as well as health. And then we talked about the whole engagement of private sector and how we can encourage the private sector to invest in the community. So we talked about needing to talk their language, needing to talk to the private sector about what their priorities are, such as having a healthy workforce, and how by addressing priorities of having a healthy workforce that will not be so ill and not need to be replaced, it's in their interest to invest in the health of those people and their families. But also how the private sector can help us with our agenda. If they're bringing things out to rural areas, can we give them educational materials? Can we piggyback on their social media to have a common goal of educating the population about what is healthiest? And then finally we talked about the whole role of the local power brokers such as the mayors and how to reach them, because they're kind of out of our realm of experience. And that by finding mayors that would be willing to sit down with us and talk about, with their power brokers, visioning about where they would like their community to be 5 or 10 years down the road, and where they are now, and what needs to happen to reach that vision. It's a natural way to bring together community coalitions to begin to address the broader issues, and that's been very successful. I think that's pretty much it. My table can mention if I've forgotten anything key. No.
Okay, thanks very much, Christy.
Great, thank you. So I was at table 5, and we were looking at how will we measure progress and success? How will we make sure we stay the course? So I don't think it was the first question we asked, but we did get to the question of who are we? And we at the table thought it was important for us to talk a little bit about that. And we ended up, I think, coming to agreement that one of the challenges with measurement is alignment, and are we all doing the same thing, and are we looking at things and defining things the same way? And I think the resounding answer to that right now is no, but we know that there are some initiatives ongoing to try and move us closer to agreement around how we measure things. And I'll just put in a plug. There is WHO, USAID, and World Bank are working on a roadmap for measurement and accountability in health. And other partners are being brought into that. There's going to be a summit in DC the 9th to the 11th of June that's going to be looking at that. So there is actually very high-level institutional commitment to this idea of making it a joint we, a common we, and aligning around measurement. I think the second point or the second fundamental question that or point that we made was, if you can't count it, can you recognize it? And it's really necessary to be thinking about looking at, and this kind of segued into a discussion around what is our reality around health and healthcare and health access and health outcomes versus what we may have been measuring previously, or some of the challenges that we have to measuring correctly. So specifically, we spent quite a bit of time talking about the private sector and how when we talk about health systems, we tend to talk about government health systems, think about it in the construct of a Ministry of Health, but it really needs to be enlarged and recognize the fact that most people in the world start with the private sector for their care, and only at the point where they've exhausted all their other options do they actually end up in the government sector, and that there's a lot of hybrid and blurry space between the two as well. And so if we are going to be measuring and looking at success and progress, we need to be including all inputs, and we need to be taking into account the complexity of the system. The last point that I'll mention that I think was very pertinent and is a challenge is the question of how do we measure failure, and how do we think about failure and what's not working. And we do a lot of thinking about how we have been successful and how do we measure success against targets, but when something doesn't work, how do we measure why, or how do we look at why it didn't work? What is the impact of the fact that it didn't work? What kinds of resources may have been lost as a result of that, and how do you then rethink it and rechannel it into lessons learned for the future? So I'll end with that.
Thanks very much. We do not have a panelist on table 4, but I know that there are 2 tables, and there was a lot of excited conversation going on. I wonder if there's either one of the members from either of the tables that would like to share some of the thoughts from your conversations.
Go to the mic.
Thank you, Stephanie Thangavello with Wars and Associates Education Co-Chair, and we took a lot of notes and did not come up with the answers exactly, but I think just some of the things we discussed were community engagement and highlighting cross-cutting efforts to be considered, linking education and health, taking gender considerations into cross-cutting issues, engaging men. We talked about inclusive development and social inclusion, looking at marginalized, the most at-risk, the invisible population, so to speak, and how we can mobilize the community to make those individuals visible and to raise them up. One of the things we talked about were gender assessments and understanding the communities and cultural implications. So a lot there and much more to go, but those were our thoughts.
Okay, thank you. And just on behalf of Table 1, a couple of thoughts. The question is, it appears to be overwhelming, intricate, intertwined, and unfair. Where do you start? Can one person make a difference? And I'd like to ask first, before I have a couple of thoughts, how many of you in the audience are RPCVs? Okay, so you all know that yes, one person can make a difference. I think that a lot of the conversation around the table was, what do you pick first, and how do you go about doing this? Most of us around the table were health professionals and development practitioners, so our inclination is to start with health, recognizing that there are other parameters that are involved. Now, we talked a bit about the intergenerational nature of poverty and health behavior, and how do we break that cycle? And at what age do we begin the conversation, and what is the optimal age? It may be labor intensive, but when we think about the one person making the effort and one person making a difference in all of our various programs, it is the health practitioners that see something going on that limits the access or limits the willingness of an individual to seek health care. Simple things such as how do you divide the waiting room into those who are HIV positive and those who are not, immediately resulting in stigma and therefore a reluctance to go to seek counseling or seek services. And all it takes is one thoughtful person to see that and come up with a solution. That one person made a difference. It's a long haul, and I think that we certainly talked about the importance of making sure that funders and policymakers recognize that it is a long haul and that it is intergenerational. And we need to be patient, but we need to stay on course to benefit the communities, and certainly to do our part in breaking that poverty cycle and ending extreme poverty. Once again, I'd like to thank the panelists, please, and thank all of you. Please join me in thanking them. And I think, Ellen, you have some final.
Thanks so much to all of you guys, and for all of you for coming. Many more people than we anticipated, and we're glad to see all the faces. And it was hard to indicate that it was time to stop because it was such rich discussion. Just a couple of things. There are more books on the table. Feel free to take one. If you've taken one and everybody's leaving and you want another one, I'm really not interested in carrying them all back. Aid was generous enough to give us the 50 that we asked for. There are extra handouts on the table. Feel free to take any of those. If you didn't get one or you want it electronically, either leave me your business card on the table over there, or there's a sheet where you can put your name and your email address, and I'll be glad to send it out. For those of you who took some really good notes, if you don't mind either giving it to me now or sending it to me, what we want to do is have some notes that we can put up. The filming of this will be up on the SID website under the conference. We'll put up all of the handouts that were there as well, a link to the Frontier magazine that's on the table, and we'd like to have some notes, so I'm going to gather notes from people. So if you wouldn't mind doing that, that would be great. So thank you all for coming, and you've got a lot more to do today, so have a good day. Thank you.